Hey guys, so Dr. Axman asked me to present a cool limb salvage case, so that's what I have for you, short and simple. So we're going to do ours through a external fixator and V-to-Y skin plasty. So about a year ago in August, 37-year-old male with past medical history of diabetes type 1, hypertension, heart failure, morbid obesity, pretty big guy, BMI of 50, and a left Charcot foot, presented to the ED with left ankle pain and swelling. He said that it started about 2 months ago when he jumped off a truck at work, which then started a Charcot flare in his foot. He saw another podiatrist who placed him in a cam boot. However, that's a typo, it should be. He felt like his ankle was inverted in the boot, and to the point that he was almost walking on his fibula. After a little bit of time walking that, he started developing callus blister, which started draining serosanguinous fluid, and then soon developed into the callus that then opened up into an ulcer that had a 10 out of 10 pain. So on presentation to the ED, you can see, he's tachycardic, BP was elevated, labs significant for high white blood count, CRP, ESR both elevated. Pulse is not palpable, they were Dopplerable. Musculoskeletal, he had the previous Charcot deformity, and it was very hypermobile joint, neurologically diminished. Dermatological, there was a 4x4 ulcer, fibronecrotic, coming out with 3 to 4 cc's of dishwater purulence, compression, erythematous, smell, malodorous, probed all the way down to the depth of the joint space. So here's a clinical picture. The probe can actually go pretty deep in that central portion of it. If you look at the x-rays, you can see, a lot of joint destruction. Doesn't look the best at all. But he, previously he was told he should probably get a BK, but patient refused and tried to do everything to save his foot. So we did a CT. As you can see on the CT, there was actually some subcutaneous emphysema over here. So, this had to go later that night. So we took him to the OR, did an IND, had him on Vanc and cefepime. Later in the mission, we then applied a wound vac once the infection was under control. ID wanted him on 6 weeks of cefazolin on a PICC line. So then we discharged him, and we told him we will plan for a possible external fixator once the fiction was fully under control with the 6 weeks antibiotics, and then once the wound vac kind of helped fill in the depths a little bit. And then just a month later, a patient called his surgeon, stating that within 2 days, the wound vac started filling up with blood 6 times for a total of 1.8 liters. That's a pretty significant blood loss. He's also complaining of dizziness, headache, and severe pain. So surgeon advised him to go straight to the ED again for medical stabilization and for possible surgical plan. And you can see at least the white blood count did improve a lot since last time, down to 8.7. Hemoglobin, hematocrit especially, was pretty low. CRP, ESR, CRP got better, ESR still a little elevated. So what was the plan? After we managed to hemodynamically stabilize him, we took him back to the OR for a left ankle foot excision of the wound, V-to-Y skin plasty closure, and application of external fixator for ankle and subtalar joint fusion. So I know Dr. Steinberg mentioned the V-to-Y plasty earlier in his thing. So basically you just kind of excise the wound and move over and transpose healthy tissue over the site. Here you can see some pictures of the X-fix in place, and then we actually managed to fully close the wound, which was actually great. And then here's some intra-op pictures where we managed to fuse the joints. The patient did actually look a lot better for a while. He went on to have it fully closed, but I think he kind of took that for granted, and he wasn't the most compliant guy. 6 months later, he got a new infection. At this point, it was a lot more extensive, so it was recommended he got the BK. So it still proves that even though sometimes the valiant efforts are made to do the limb salvage, if the patient's not working with you to keep the limb alive, it's hard to have them change their habits. That's it. Thanks.